Okay, some of you either listened to already or heard before, had previously listened to the sort of introduction to the nervous system where we talked about some of the brain and spinal cord stuff together. Now we're just going to skip over and talk just about traumatic brain injury. Like every other lecture, there's going to be a bunch of introductory stuff and a whole bunch of medical things that I'm going to fly through really fast. So let's just kind of get cracking at that because the stuff I really want to get to that's really important is going to come towards the end of this. So there's a few ways to sort of generally talk about traumatic brain injury. Some of you might have heard of the term acquired brain injury, which means it didn't come from a traumatic event, but it just sort of happened. Examples of that are like um, uh, bacterial infections in the brain. We've talked about those before, or we will talk about them more as well. It might be cerebral palsy that happens. I guess that could sometimes be considered traumatic, but it's asphyxiation at birth. Have the cord wrapped around your neck, or for one reason or another, you are oxygen deprived, so your brain you lose some functioning or something like that. But that's a different thing. We're talking about traumatic brain injuries here. But there's a lot of similarities and stuff too. So whatever. I guess I'm just complicating this now. It can refer to all injuries, from mild concussions to severe cranial damage, cranial being skull. The book talks a lot about blast injuries, which we'll get to, only because, and we'll hear more about this, but because they don't seem to fall into the category of either an open wound or a closed wound. Concussion is like your cranium is intact, and so you can't really see in or look in or anything like that. But open wounds mean there might be bone shrapnel and like lacerations and that kind of thing. Another sort of kind of random point is injury at any age will cause functional sequela, and I'm going to use some of these terms so we can start getting comfortable hearing them. Sequela meaning secondary complication actually literally translates to following. So following the injury, these other things are going to happen. Injury will cause functional sequela in later developmental stages. So depending on the age at which somebody has the injury, whether it's in infancy or in teenage years or adult years, that's going to change their functional capacity later on. So that's maybe a little more than we want to talk about today just because of timing, but just a simple example is if somebody is injured in their teenage years in a sporting accident, like, I don't know, playing football and you get a concussion in high school or something, they may have already developed, a lot of their social belongingness and their sense of identity of who they are, but because some of those higher order functionings of the brain may not be fully developed yet in a biological sense, then they might not, those things might be more challenging in terms of like a lot of those executive functions. Things like social inhibitions and impulsivity and some of those kind of things that are common in teenage years. Also, when we think about just like our identity and who we are as people, and especially as we think of vocational identity, if somebody gets injured in high school, it really challenges who they are as a worker and how they can make income. So for rehabilitation counseling, this is really crucial and important, is that somebody, their income is going to be damaged or threatened, I should say, very, very likely if they happen to get injured at that time. Somebody gets injured in a motorcycle accident at 29, and they've already kind of found their career. They're much more likely to either maintain the career or find something else that's going to continue to work, even though their injuries might be more severe. So just that's something we can get into later if we need to. Physical sequela or physical consequences following an injury might be physical inactivity, weight gain, other behaviors. I love it when people say stuff like that, like these four things, and then everything else might be possible too. Because I think it's funny because it tells you almost nothing. But an example might be weight gain can lead to obesity, which can lead to heart disease, and then impulsive choices or not understanding nutrition can lead to things like diabetes and that kind of stuff. And all of it compounds the initial injury. There's three factors to consider when you're thinking about how is this person going to be affected. One is what is the type or cause, which we'll see below here, of the injury. What is the area of the brain affected? And what is the extent of the injury or the severity of it. And then we're going to talk about these three types, which is closed, open, and blast injuries. So that's what we'll kind of break down a little bit more. Let's talk about closed injuries first. They can happen from all kinds of stuff. Motor vehicle accidents, falls, direct blows, sports injuries. These are the most common, I think. They can be focal or diffused. Focal meaning kind of focused on one specific area, like if there was a gunshot or something like that. Or remember the Phineas Cage story? He was a I didn't tell you this, but some of you know he was a railroad worker, and they used to stick down dynamite into these like kind of take a ramrod and shove dynamite down in the ground so they could blast out these different areas of rock and stuff to make sure the trains go through. And he was ramming it down, it exploded, and the ramrod went right up through his brain, and he got focal injuries to the frontal part of his brain. Or it could be a diffuse injury, which we'll talk about in just a second, where you get hit on this side, and then well, actually, let's talk about that as we go to the next thing. In the primary phase, an example of a diffuse injury is this thing called coup and contra coup. So you can think of that kind of like back and forth. Coup literally means a blow in Latin, and contra means against or opposite. So you have this initial blow, and then your brain goes, as the force hits your skull like this, your brain squishes up the front part of it, and then as you get move backwards, it kind of like, jostles. Is that even a word? Jiggles, joggles, something like that. It gets hit and it goes, and then it hits this side, and then it just kind of bounces like jello back and forth. That would be a diffuse injury because it's affecting this side and then this side, and depending on if you get hit here, and the injury might be back here, front here and back here. If you get hit on the back, it's going to affect this differently, and then this part, and just, it gets a little complicated, but you try to piece together in the primary phase if you know what happened and where a person was hit, that kind of thing, then you can say, well, here's where I should be looking for some intervention. The secondary part of this is by the way, the primary phase is like happens in seconds or minutes or something like that. It's the thing that happens quick that produces the damage. And then there's secondary. Sorry if you can hear that. Someone's calling me. Phones are distracting. Speaking of attention span injuries, we'll talk about that later. I have an injury that I carry in my pocket all the time. It steals my attention and harms my memory. Anyway, the secondary phase is edema or swelling. There's also intracranial hemorrhaging, which is like an open blood wound that sort of bleeds openly and everywhere. Or a hematoma, which is sort of a localized sac filled with blood. Some of you have maybe had this, like, you hit yourself and you get a bruise and it just goes like that. It's just a hemorrhaging vessel or something like that in your body. Versus a hematoma, that if you ever had like kind of a little spot where you had like blood blisters, that would be an example, I think. But those happen in the brain as well. The big deal with those is it creates pressure, and that's the big problem here, is that all this stuff can create pressure, and when there's added pressure on the brain or in certain parts of it, then it reduces the blood flow, which means reduced oxygen. And if the blood flow is restricted or an oxygen level is restricted, that can create further damage to the tissue. So it's not necessarily that it's like this initial part that like half of your brain cells are dead, which can happen. But the secondary cause is that, okay, now I got hit and my brain is in shock basically. And then added pressure in the brain says like, okay, well, it's just kind of, cutting off life to the rest of the parts around it or on the other side of it or whatever. And that's the concern. So depending on the type and location, it can lead to varying levels of functioning or consciousness. And consciousness is one of those things that we really want to measure to understand how severe this is, because when you get hit, one of the responses is you lose varying levels of consciousness. So we'll talk about some assessment scales, how we can look at that kind of thing too. But one of the things worth mentioning is that early intervention can prevent long-term consequences. So probably several of us in this class have had concussions before. I know I've had at least one. Most of them are related to snowboarding accidents. Excuse me. I was snowboarding and I went off this jump, and I'm not going to tell you the details because you're going to think I'm an idiot or you're going to think I'm really awesome. But I was pretty decent at snowboarding back in my younger years, and I went off a jump and I over rotated a front flip kind of looking thing, and I landed just like flat on the ground, sort of overshot the landing completely and landed flat on my face. And then I don't know how long I was skidding down the hill, but I was skidding down for a while, and I was really embarrassed because I was like in 8th grade and I had scrapes all over my face and stuff, which was to me the biggest deal. But the biggest thing probably was what was going on up here, and I never went and got it checked out. Didn't know what to do about it. But the challenge is, I mean, I was super confused and I just didn't know what was going on. But the challenge, what I should have been caring more about is what's going on up here and how could that have affected me later on. So now that some of you know me a little bit, you might be like, oh, that explains a lot. And I get why he's like that now, which be interesting to hear you say that. But anyway, continuing on with closed head injuries. Oh, that's the wrong way. An idiot. Okay, open head injuries. So we're shifting gears a little bit. Now we're not talking about what's going on the inside and this pressure and swelling and all that kind of stuff. We're talking about the open head injuries where the skull has been ruptured somehow. Oftentimes these can be a little bit more localized. So remember the focal or diffuse thing we were talking about earlier? If it's localized, the skull broke here, and this is an issue right here. So you're dealing with potentially lacerations from whatever foreign object went in or whatever, or just bone fragments that are sort of cutting and slicing little parts of the brain, that kind of thing. So potential for lacerations. Increased potential for infection, because now that boundary and barrier of the skull and all the different layers in there, the dura mater and the pia mater and all that kind of stuff, all that stuff is protecting the brain from outside stuff, and now that outside stuff is in there, and so infection is a big concern for this, for open head injuries. And the third category, I just kind of tagged it onto the end here because it's still something that we don't really well understand quite yet. But when you get blast injuries, your brain may not actually be opened, although it could, but it could be an open or closed injury. But in either sense, it doesn't have this coup and contra coup effect, although that can happen, like if you're blasted and you hit a wall or something like that. But it also has just like the shock wave. If you ever been around like I don't know, like been at some like air show and the plane goes by and your hair goes like that. Imagine, being next to an IED in some other country and it explodes in your Humvee, and all of a sudden like the sound waves and all that pressure and all that stuff are just sort of like going in and going and like shaking and tearing and doing all kinds of strange things. But it's not going to happen in one particular spot. It's not going to have like this this motion that we associate with it. So it could happen all over the brain in different areas, and it's just kind of like, I guess, tissue shock, for lack of a better term. But we're still trying to understand, not we, I'm not trying to understand it. It's people smarter than me who work on the actual anatomy of the brain. They're trying to figure out what's actually going on there. And how do we understand the potential future outcomes? Because if we understand like localized areas, if you got hit here, we can say, oh, that's why it's affecting your speech or something like that, and then we can provide interventions. But with these blast injuries, things are just different, and we don't really understand which parts are being affected more than others and that kind of thing. In other words, like, are there some more fragile parts of the brain that are more commonly affected versus more durable parts? Or there's just so much that goes into that is beyond the scope of what we're talking about here. Okay, I mentioned that there'd be some assessments. These are two, more than two, but kind of the two big ones that you should be familiar with. The Glasgow Coma Scale and the Rancho Los Amigos, not Ranchos. The Rancho Los Amigos Cognitive Scale. So these are both basically, they're given really quickly after the injury so that they can set a baseline for how severe is the injury. And then later on, when you come back and look, you can say, let's do the same assessment and talk about improvement or development over the course of time. So in the Glasgow Coma Scale, scores range from 3 to 15. Actually, you know what? I'm not going to read this. You guys can read this one. There's a few other additional ones that are part of this Glasgow thing in terms of like measuring functional capacity and the things you actually can perform. The Rancho Los Amigos is a little more like that, where it's used for measuring functioning and consciousness. But what it's really for is to say how severe is the injury, and your like level of awareness. That's really what we're trying to understand here. And are there associated behaviors? Because there are some behaviors like extreme agitation and physical violence that come along with early stages of brain injuries and stuff. So that's what we're trying to understand here. Basically, if we have a score that's related to how you're doing right after the injury, we can really understand a lot about what happens later on and what the likely outcome is. That's really the goal of this. Here's a few that explain kind of the range of these as far as severity, especially considering the Glasgow Coma Scale. So I'm not going to talk about these. I think I'm just going to sort of fly past those, but what's on the screen is pretty self-explanatory. Except for this last part. Just because you have a score of 8 or less does not necessarily mean you're in a coma, but it can mean that your coma lasts longer or is the kind of vegetative state that'll lead to future consequences, stuff like that. But you can look at the scale itself, just Google it or whatever. I'm trying not to say Google because Google is not very popular right now, but you can do an internet search to find that exact scale, and it's widely available and easy to find and that kind of thing if you want to look at what are the actual metrics of it. Okay, manifestations of TBI. We're going to start being a little bit repetitive here, but this is also where I'm going to fly through and talk really fast so I can get through a bunch of this stuff to get onto the real valuable stuff later on. So physical functioning can be affected, movement and balance. You can have hemiplegia. Remember we talked about the crossover of the brain and effects on this side will affect this side. Hemiplegia just means paralysis or limiting functioning of one side of the body. Could be, it's not just like paralysis, but it could just be like tingling and numbness and all those kind of things too, depending on severity. But hemiplegia refers to, hemi means half, and plegia means like loss of functioning, basically. Dyskinesia or abnormal movement. Some of you maybe have heard of the condition called tardive dyskinesia, which has nothing to do with brain injuries, but it's a consequence of taking medications, basically, usually antipsychotic medications. It can lead to tardive dyskinesia, which is just like abnormal movements like tongue sucking and movements of the jaw and sort of just like really quick movements, and it's noticeable to other people, but not necessarily the person that has it. They don't notice they're doing it right away. So dyskinesia just refers to that sort of abnormal movement, and that could be in any part of the body here when we're talking about TBI. Dystonia, we're talking about muscle tone here. When you think tone, think of like flex. There's kind of two kinds of this. There's flaccidity, which is like a limp muscle that doesn't really do much, when it kind of should. And then there's spasticity, which you'll hear quite a bit, especially when we get to the chapter on spinal cord injury, and that's too much flex. So muscles that get tense and just like they have a hard time relaxing, something like that. And sometimes this happens in kind of like a jerky way. Like if you think about if you ever been lifted something really heavy and you lift it up for a while and you're like, yeah, I'm so ripped, I can do this, and then you start to get the shakes. That's kind of what it looks like, because if your muscles are spastic, that means they stay tense for too long and they get tired and then they get the shakes. And so it ends up looking like shakiness, but it's really just spastic muscles from too much muscle tone. We'll fly through these. Coordination can be affected. There's a lot to say about that, but we'll skip it. Fatigue and endurance. Fatigue is a really big one that happens to a lot of people, that especially even in like mild concussions, you'll hear about people saying like, oh, I'm really fatigued, and this is one of those ones that's hard for us socially to understand. Someone just might look lazy. You'll hear family members say, like, he just sits around the house all the time and he's got so many things he should be doing. He's got PT and OT and all these other things that he's supposed to be doing, and he just sits there because you get tired. It's just one of the things that happens. Eating and swallowing can be a challenge. Bowel and bladder functioning can be affected by brain injury. Continuing that same list. Perceptual manifestations, you can read these. I'm not going to spend too much time on these. Recognition, agnosia is a word you'll hear sometimes. The inability to recognize words, faces, or objects. Anosognosia. By the way, part of the reason I'm pronouncing these is so you can hear them pronounced, because sometimes it's hard to do. Anosognosia is non-recognition of one side of the body or the other, or one side of like your visual space. Just really fascinating stories. If you ever heard of the name Oliver Sacks, he writes these books, kind of like quirky science. That's kind of a trite way to put it, but like he tells these stories of patients that'll come in, and one of the stories he really told was of a lady who just like you tell her to draw a picture, like draw a square, and she would literally draw like half of the square and then be like, "Yep, I'm done. It's all there." And it was only half a square. It was just totally fascinating. But that's what that means. Anosognosia is not recognizing a part of your visual space or auditory space, or it could be any of those kind of things. Visual space relations, challenges there, challenges of vision and hearing, comprehension of sensation, so not feeling things when you should or feeling things when you shouldn't, could go either way. And that sensation could be audible, it could be visual, it could be touching, it could be all kinds of things. Speech, this is referring to not only articulation, but there's all kinds of different ways that we use that we do speaking. Sometimes there's damage to the muscles, so the muscles can't quite do the thing that your brain wants it to do. In the other case, your muscles work fine, but your brain can't articulate the things because it just can't put them together somehow. There's another term for that in your book too. And then language, aphasia, inability to communicate in speech or writing, or anomia, which is that sensation of like you can't find the right word, something like that. By the way, there's a whole bunch of other terminology and conditions that come up with this, but I was trying to be limiting to the most common ones that I've heard anyway. But you will likely pick up more if you're working in this area of TBI. Cognitive functioning. Now, we were just talking about physical functioning. Now we're switching over to talk about cognitive functioning. Memory and learning. Some of these seem kind of obvious. One of the things to highlight here is this word confabulation. This one can be incredibly confusing and difficult for people around the injured person, where somebody has no intent of lying and they're not trying to be deceitful or misleading or anything, but they think they're actually giving positive and factual information when it's just not. Like, oh, I just went to the grocery store. Yeah, I was with Karen, and her and I went and picked up milk. And you're like, no, you weren't. You didn't do that. I mean, it's probably not like that exactly, but one of the things this can really look like is it can look like psychologically manipulative behavior to get what you want. It can look like gaslighting and being deceitful and an evil genius or something. But in some situations, even in psychological situations, sometimes people are bad people and they're doing bad things to get their way. Other times, it's a coping strategy to deal with trauma. In this case, it's a physical strategy, or it seems like it is. Has a physical relationship to brain function or malfunction that says, I'm going to record information in my brain as factual when it is not actually factual. So it can be really confusing because people are we're starting to train ourselves to see this as evil behavior and manipulative and as a coping strategy to cover up something and repress stuff. But this is even becomes more challenging because now we're talking about, no, it's not about that at all. It's not about this person trying to be a certain way or psychologically compensating for something. It's just, misregistry of the brain. And so this can get really complicated and confusing if you work in this area. And even more so for the people that are close to them. So we'll get more into that kind of stuff in a little bit. Attention and concentration, information processing and concept formulation, problem solving and decision making. All of these have so many things to say about them as explanations. The book had a really good one related to, I don't remember the story now, but it was something about when you go, if you take the bus and you say, okay, well, I have $5, I'm going to take the bus, I'm going to go grocery shopping. Great, here we go. And I've got money for the grocery store. Then you get to the grocery store and you spend all your money on groceries and you're like, I'm making it. And then you get back to the bus to go home and you have no money left. And because you didn't think about that ahead, you didn't plan in advance. It's that kind of stuff that can really make planning and navigating challenging. Is because you can plan for only part of a trip and then miss the rest of it or something like that. So those are the kind of interesting situations that are challenging and really difficult. Judgment can be affected, impulsivity, and one of the particularly challenging things is sort of self-regulation and self-awareness. So even being aware that you're being impulsive or aware of the way that it's affecting others, if you think there's nothing wrong with my behavior, this is what it is. One of the interesting things that can happen is first somebody's not aware and you're using that coping mechanism of denial, like, no, this is not a problem. And it's just sort of like something the brain can't do. It may not be psychological, it might just be a brain function they can't do. A person is in that denial, and then if they start to say, like, okay, now I'm recognizing there's a problem, I'm hurting other people, I'm not doing things in a functional way, and then that can develop into other strategies like anger and frustration and irritability and that kind of thing. So the more a person starts to recognize it, they can have different kinds of reactions to that. So it gets really interesting and complicated, but that's one of them. Personality and behavior. This is what we're going to spend a little time on, but this is our main wheelhouse as counselors. Paying attention to family reactions and adjustment of person or behavior. So the way a family is reacting to the individual because of their personality change can be a hugely important factor in how well the individual develops. Because the family starts to say, well, to use the example I had earlier, the person's just lazy, they're just sitting around, they're impulsive, they keep saying mean things to people, and they keep getting in trouble at work, and they keep, all that kind of stuff. There's a tendency to kind of villainize the person, and nobody would probably blame that family for feeling that way. Because in most circumstances, we would look at that person and say, they're impulsive, they're difficult to be around, they have a nasty way of relating to other people, and we need to set boundaries with them, and in some cases just leave them. That creates other challenges though, right? You can imagine how this gets messy really fast. So one of the things you want to do if you're working in this area is, if you can, train the family to understand, how do you take in this kind of thing without getting exhausted and burned out. And that means that in your training, you first got to figure out, how do you do this stuff without getting exhausted and burned out? Because it can happen, right? As you can imagine. So I can show the family, like, look at how I respond to this. Look at how I handle this kind of behavior. Look at how I do this. And a lot of this is just modeling at first, and then giving them some skills and training so they can eventually say, okay, what I'm going to work on with this individual is, we're going to work on after we cope with all this initial injury and after we go through some of the early stages like denial, eventually we're going to work on that. You guys don't have to right now. It's not your job to tell this individual that, hey, you're not actually seeing those things. That never happened. You don't feel this way. You can't act this way, that kind of stuff. There's a tendency to want to correct so fast, and that can get really challenging. So in many senses, you're working with an individual, but you're also working with the people that are around him. If you're going to do strictly vocational counseling, you're doing a lot of work-related stuff in the later stages of rehabilitation. So we'll leave that one there. Okay, continue on. More things about cognitive functioning. We've already talked about disinhibition, anger, depression, self-awareness. So we're going to talk a little bit more about this, but I want to tell you one quick story here. One of our important developmental tasks is developing a sense of identity, right? We've mentioned that before. And there's a guy named Jim. He actually happens to be my uncle, but he's calls himself a neurotheologian. He was a psychologist, and now he works mostly with churches and dysfunction in church communities and that kind of thing. Really interesting guy, and whatever. So he tells this story about, he used to work at I'm going to get all the details wrong too. So if he ever hears this, he's going to be like, no, dude, don't even try that. That's not how it went. But he used to work at like a summer camp or something like that. Or he was participating at a summer camp, maybe doing a talk, or maybe he was a participant, I don't know. But there was a lady there who, when you go to the cafeteria, imagine like the cafeteria at a summer camp where everybody goes and you go through the lines and then you come and sit down with your food and socialize, whatever. Well, there was a lady there who was just really difficult to work with, and everybody was just like, they knew her when she came. She didn't wait for the line. She would run right up to the front and say, I'm going to get my food, and she'd push people out of the way, and she'd take too much food, and then when she was done, she'd haul back up there and take it. When normally we would wait for seconds and see if it was appropriate and all, wait in the line and all that kind of stuff. So as you can imagine, it was really tiring for people. It was difficult to understand why she's doing these things, and maybe even more difficult is, what do I do about it? What's my reaction to it, right? So one day Jim was out hemming and hawing about this, and I don't know if he was like complaining or if he was just sort of thinking about it or talking about it, and he was talking about this guy. And as he was talking, the guy said, well, that person is my wife. That actual person who's doing that is my wife. And so they got to talk a little bit more about it. And what happened was both of these people were Jews in Nazi concentration in Germany, in a concentration camp in Nazi Germany. And what was routine in concentrations camp was to do these like routine lobotomies for people. So they would just literally stick a pick in their foreheads, and like we talked about earlier, just awful, awful stuff. And one of the consequences of that is personality changes and behavior changes. And one of the questions that Jim asked this guy, he was like, "Well, how do you deal with this? How do you manage it? What do you how do you stick it out essentially?" And he's like, "I remember that woman and who she used to be. She was a concert pianist and the woman that he loved. And this man remembered that lady and said, she's the person I married. She's the person I care for. And this, what I see now, is only a shadow of her former self. And I still love her and I still care for her." So I say that, and it's put in this depression setting here, but when we think about how we conceptualize the person and their behavior and all this kind of stuff, what we have to remember as counselors is that person used to be somebody, something to somebody, and they used to be somebody to themselves. And so we need to really capture what that is, and we need to understand, like, okay, this is a new person, we're adjusting to a new person, new personality, new behaviors, all this kind of stuff. But one of the challenges with many forms of counseling is, how do you integrate the good with the bad? How do you understand somebody with this condition now who's super frustrating and they just can't get it or whatever, versus what their potential is and what they could be in the future, or what they have been in the past. So hopefully that makes a little bit of sense to you. But it's one of the challenges that we get to ask ourselves: how do we do that? We're not going to get too much into that, unfortunately, in this class, but it's something we'll talk about in a little bit, I guess. Okay, associated conditions. I need to keep going relatively quick because we're getting to the good stuff. Post-traumatic seizures, so seizures that happen within 24 hours and are usually related to the intracranial pressure, the edema, the swelling, that kind of stuff. Epilepsy is more of kind of a long-term condition as a result of that. Seizures are what epileptics have, but epilepsy is the condition that's chronic and long-lasting. If that makes sense. Post-traumatic hydrocephalus, increased cerebral fluid in the brain. So what happens is you have this cerebral fluid and it's developed and then reabsorbed by the body in different ways. And so there's this kind of constantly right amount, so to speak, that homeostasis, balance, equilibrium of the right amount of fluid. What can happen is that fluid can build and grow, but it creates pressure and it can't be absorbed by the body or removed from that space. And so in that case, what sometimes happens is a shunt is put in to drain that fluid, and it's usually put in up into the cranial cavity and it goes down into the abdominal cavity. The shunt never leaves, but the draining may stop over time once it kind of reaches the equilibrium. So that can be a condition that happens. Chronic traumatic encephalopathy, which is just the continued deterioration of brain disease even after the injury. So sometimes you get hit and you're like, well, this part's dead. And then other times you're like, oh, it gets hit, and then there's this pressure and it builds up and it kills other parts. And then there's this encephalopathy, which is just, for maybe unknown reasons, sometimes the brain just continues to deteriorate and parts of it sort of die out and stop working, that kind of thing. And then the book kind of tacks this on in different areas, but they talk about substance abuse, particularly if there was any kind of addiction before the injury. There's a risk of continuance, of course, because there's more stress and all that kind of stuff, or beginnings of substance use. And it happens for a lot of reasons, but just imagine this happening to you, and now all of a sudden you're not working and your life is different. You're sitting around all the time and you're extra sad and extra depressed and all kinds of stuff, and you're just looking for ways to cope. You can imagine how somebody would pick up whatever's available to them and use it. So, worth mentioning, but we won't talk about too much. Okay, management. Now, what's the process for how you deal with this in the early stages? This is kind of before counselors get involved, but it's good to know this stuff. There's a treatment team of all these different kind of uh, all these different kind of people of different jobs, and it's an enormous list, and it's even bigger than this probably. But there's well, it is bigger than this because there's financial people that aren't mentioned here. This is the medical team, but you have, like, how do you deal with your finances? How do you deal with your kids at school and their teachers and the behavioral outcomes of how they're reacting to their parents' issue, if that's a situation, or they're reacting to their injury at school. And so, like, it's bigger than this. But you have neurosurgeons, neurologists, physiatrists, which is just like a disability doctor, to put a, kind of generic term on it. Nurses, respiratory therapists, physical therapists. Um, you can read the rest of them. SLP is speech language pathologist, and OT is occupational therapist. Those are common abbreviations, so I just put them in there as that, but that's what they mean. In the initial management stages, this is like you go to the ER and you're in the inpatient rehab facility or whatever, or at the hospital, I should say, and you're really just trying to stabilize the condition, reduce edema. Contractures can be an issue. So contractures means the mobility of joints. If the muscles get stuck in a certain place or the joints don't get practice moving around and stay in use, then they can get permanently limit the person's flexibility and ability to move. So that's why sometimes you'll see in different kinds of conditions, especially spinal cord injuries and brain injuries and burn injuries and all that kind of stuff, where you'll see doctors saying, okay, we have to move, we have to get up and use our body. Otherwise, it'll get used to being disused, essentially. And then shunting and craniotomies. Craniotomy is just like opening up and taking care of things, basically. Post-acute management, so that's the acute phase. Now, after that, this is where the counselor can get involved. There's physical therapy, there's neuropsych assessments for like how is the person's cognition working, and sometimes their mental health and social functioning too, but usually neuropsych assessments are focused more on like intellectual assessment and personality assessment, so behavioral planning, but mostly like cognitive planning and understanding of what their capacity is, that kind of thing. And then counseling for family and behavioral management, that kind of thing. Speech language, it's not just for talking and communicating, but also swallowing. That's part of an SLP's job. Okay, let me just check real quick, actually, how much we have left. Okay, sweet. So we got about 10 minutes now. We have 3 slides left, but this is really the stuff I wanted to get to. So I might go a little bit over the 45 minutes, but I'll try. Functional implications of TBI. What we're talking about here is personality and psychosocial issues, and that's where we start talking about coping, and we start talking about how a person behaves. What often happens with people with high behaviors, this is not just people with brain injuries, but we're talking people with personality disorders like, antisocial personality disorder, narcissistic personality disorder, borderline personality disorder. They often end up in prisons. Like, that's just kind of a thing. Criminal behavior is associated with some of these mental health conditions, particularly personality disorders, which means it's a highly regulated behavioral environment. For people that don't end up in prison, and this is, I don't mean to make it sound like if you have that, you're going to jail or something like that. But for people with things like, if you're on the autism spectrum, we talk sometimes about, sometimes the intervention of choice is applied behavioral analysis, because it's a behavioral condition that we can use things like operant and classical conditioning, such as rewards and negative and positive reinforcements and that kind of thing. So with a person with brain injury, that's one of the things that gets used, is how do we provide positive reinforcements and negative reinforcements for behavior. That's one of the primary ways in which, primary forms of treatment, because it provides more structure, a little bit of restriction, so to speak, and it's less like talk therapy where you say, well, how does it feel to be like this? And it just doesn't seem to work in the same way for those folks. Because of the limited capacity to understand and make meaning and all that kind of stuff. That's not to say there's not a place for both, though, and that's the point here. But when we're talking about all these things, and we're talking about how do we deal with these, if you are the person that says, I'm a talk therapist, and now I'm going to work with this person with TBI, you're probably going to be working in the later stages of how do you deal with the family or the individual after they've kind of gone through most of the recovery process, and they're trying to resort out, how do I manage my lifestyle, that kind of thing. If you're in the early stages, if you're like a cognitive behavioral therapist or a behavioral therapist, or you're doing other things that allow for more of that like operant conditioning, management of consequences, if you're doing like cognitive rehabilitation, that kind of stuff, that can happen a little bit earlier. And so you're going to see different presentations of if you're working earlier or later, but in different ways. And so that's the part we want to sort out. We probably won't have time to go in too deep into this, but blame of self and others relating to the cause of the accident. This can be an early thing. It can also be a late thing. So in an early sense, sometimes you'll get people who have this brain injury and they're like, I was in a car accident. I have memory, so I haven't lost it to amnesia or something. I have memory of it, and it's that guy's fault, and I will never forgive him, or something like that, right? Or the reason I can't do this is because you, doctor, are telling me I can't leave this place, and I hate you. Or maybe it doesn't come out like that, but you get the idea, right? In later stages of rehabilitation to understanding your coping mechanisms and all that kind of stuff, sometimes you may not even recognize that there's an issue, and that lack of self-awareness, if it wears away and the person starts to become aware of the condition, that they're like, I don't have any limitations, I don't know what you're talking about, and then they start doing that, then later on stages they might start blaming other people for, well, okay, I do have a limitation and now I'm mad again. So that kind of thing can come up in different places for different reasons. So that's just kind of an example of that. Denial or recognitions of limitations, early, later stages. So anger and rationalization is a reaction to recognition. So imagine a person in their later stages of rehab starts saying like, well, okay, now I'm recognizing that the way I'm treating other people don't work. And I'm going to maybe do what I just told you about, like go back and blame the person for, okay, now this new challenge is going to be bothersome because that person made this happen to me. Or it could look like anger. Or it could be, I'm not responsible for this. It's that person's fault. So I don't have to do anything about it. I have to recognize it, but I'm still going to be mad and I'm not going to take responsibility for it. So hopefully you're starting to kind of see this is sort of how these things turn out and why they turn out the way they do. There's a whole bunch of other stuff too. The book just really breezes over these things so quickly and doesn't really explain them in a way that, for me at least, that I say, oh yeah, I see now the picture of the person who this happens to. And part of that is probably by design, because there are so many different ways this can look for different people at different ages and different life stages and all kinds of reasons why it looks different. But anxiety, guilt, feelings of worthlessness, depression, PTSD, particularly if you look at the symptoms of PTSD, like nightmares, flashbacks, all those kind of things, those can show up. So some of these are like, by the way, if you see me like swatting at my face, it's because there's some like thing floating around here and it keeps landing on me. It's not a bug, it's like a fluff or something. Anyway, some of these are like emotions, some of them are like coping strategies, some of them are clinical conditions, and so the book doesn't really break that down enough, I don't think. But definitely you'll see mixes of all these things if you start working with this population. So the question that I want to answer here, and I'm going to do this as quickly as I can, but it's not going to be sufficient and thorough because the book doesn't have it, and we just don't have time to cover it in this class. It's not the scope of the class. But what do you do about this stuff? Like, what are the interventions? You as a counselor, individual or family or whoever, maybe they come together. They come to you and they say, okay, all these things are happening. And all the stuff you just learned about, like that's my backstory. Now I've sort of changed. I can't think as clearly, and I'm just struggling to function. And like I lost my job because I couldn't do it for a couple of years, and now I can't get another one because all this stuff. What do you do? So a couple things. This is going to be totally brief and insufficient, but we're going to do it anyway. One of the things is starting to understand, what am I responsible for and what are other people responsible for? So we talk about this in relationship to boundaries in all kinds of other places, with couples, with individual therapy, with group counseling. You talk about boundaries everywhere in counseling. That's like the nature of our work. Part of what boundaries are is, these are my emotions that I need to care about. Those are their emotions they need to care about. These are the actions that I need to be responsible for. Those are the actions that they're responsible for. These are my thoughts. These are their thoughts. So typical example, it would be like, I don't want to go home for Thanksgiving because this is one that I just heard recently. I thought it was fun. I don't want to go home for Thanksgiving, but my mom makes me feel guilty about it, so I do it anyway. By the way, this happens to a lot of people in holidays, right? Like, I don't want to do the thing, but they're going to be mad, or they're going to give me a guilt trip, or they're going to be passive aggressive about it, or they're going to do this thing, so I'm going to do it anyway, even though it's not in my best interest. or it's not the life that I want to live. In other words, I'm acting responsible for the way that they are going to respond to this. So I'm not taking responsibility for what I have the power to do. I'm doing it because they're telling me to or making me do it. And then it leads to all kinds of resentments and all kinds of other issues, right? The issue with brain injury is helping a person realize, okay, this happened to you and you have every justification for blaming that other person for your accident, or blaming your life situation, or blaming the doctors for doing this, and blaming your family for being annoying, and all this kind of stuff. But you can't change that. The only thing you can change is the way that you feel about it and the way that you respond. So learning to take responsibility for, okay, I can't change the past. What can I do now within my capacity to take steps forward? So all of this stuff, anger, denial, blame, frustration, irritation, complication, like all the negative things that happen that somebody has complete license to feel crappy about. And nobody blames them for it because you're grieving, right? And this is the hard part. It's like you can be that way and you have every reason to be. Or you can, sometimes people use the word forgive. Forgive yourself, forgive other people. You can choose differently. You can take responsibility for it. There's kind of different ways of saying the same thing. So that can be one intervention of saying, okay, what's your role and what's their role? What do you need to take care of and what do they need to take care of? How much do you depend on other people for this support? And how much do you say, no, I can handle it, thank you very much? Sometimes you say it in harsher ways, like, no, get off me and leave me alone. I'll deal with myself, right? And sometimes you just need to say, no, this is my territory, not yours, something like that. But finding that balance and finding where the boundaries are to be set is the confusing work of counseling. So the other one I kind of just alluded to, but finding a balance between feeling supported and respecting individuality. That's a big topic in rehab counseling, in the disability world in general. So my ability to do things is changing. Some people are going to want to be really kind and they're going to want to do things for me, sometimes creating dependence on them. Other times, they're going to expect me to do things when I can't. And so figuring out what the balance is between families and other providers and the individual of when they can advocate for their own individuality and their own capacity, functional capacity, and when they need to rely on others for help, and how much you need to train other people sometimes to understand where you're at, because sometimes they'll want to do things for you when they shouldn't. Sometimes they want to expect things from you when they shouldn't as well. So it's challenging, but that's what the work is. And then appropriate grieving. Like I said before, blame, anger, denial, grief, all that bargaining, all that kind of stuff, there are stages of grief. It's okay until it's not. You can be angry, but you can also choose not to be. And part of the challenge as counselors is figuring out, okay, how long do I allow this to go on and how much can I stomach of it? And what's helpful for when do I lose my therapeutic stance with somebody because I'm frustrated because of the countertransference based on the way they're treating me. It's just like, this is where the challenge of counseling comes in. But appropriately grieving for the appropriate time until you're done. How long is that? In what ways is that? What does that look like? That's the hard part. You just kind of got to see it to understand it. Okay. Functional implications. Activities and participation. ADL stands for Activities of Daily Living. We'll talk more about that as we go through the course. That includes social participation as well as just what can I do within my own life, the activities that I need to do, like eat cereal in the morning and wipe my butt after I go to the bathroom, those kind of really basic things, as well as get to church and go to the store to fix my car or buy parts for it or whatever it is. Assistive devices and home modifications. So this is a big topic we'll get into later in the course, but what we're thinking of here is like safety. Like if my attention span is changing, diminishing maybe, forgetting to turn the oven off could be a safety hazard. Leaving doors unlocked could be a safety hazard. Leaving the bathtub running could be a safety hazard. That kind of stuff. That happens all the time. You'll walk into someone's house and they're watching TV and the vacuum is running in the background or something like that. Functional implications are also operating a vehicle, nutrition and hygiene. This is a really big one because people change their diets and they forget to eat healthy and they forget to manage that part of their health. Cognitive functioning, I mention that all the time, but one of the things you'll see a lot is like calendars and alarms and reminders and sticky notes and apps for everything, right? Sexuality, again, here I mention it. Um, this can be like both biological and psychological. So when it comes to sexuality, relationships change, especially if a person has a spouse or they're looking for a partner or something like that. It could be related to like anxiety, so performance, like I can't get an erection because I'm so anxious, or um, I can't get a date because I'm too strange or impulsive, or I say mean things or whatever. It can affect current marriages because, if my personality changes, then you have to sort of readjust. Like, do I want to be married to this person? That kind of thing. This wasn't, it was kind of alluded to in the book, but it's an interesting question about family participation and sexuality, and all these things kind of blend together. But divorce rates, higher or lower? One of the things we know about disability in general is divorce rates are much higher than the general population. However, with TBI, there's some new research coming out. This is part of your content quiz for the week, for those of you that are in the class. What would you expect? If a person has a totally new personality, would you expect there to be more divorces or less? As it turns out, there are less, which is not sort of the intuitive thing that most people would think, especially given the research on just general disability and divorce rates and that kind of thing. But you as a counselor might have somebody who says, my husband just got in a motorcycle accident. He's totally different now, and it's affected our love life and the way that I care for the kids and the way that we, he's not working, so I'm taking on more, and I'm exhausted and I'm frustrated, and he's being a jerk, and this kind of thing. It's not uncommon for people in the therapy world to be working with somebody in that situation. So whether you're going to be working in a hospital medical setting or you're going to be doing a totally different role, it's probably likely that you'll encounter somebody with some family relationship to traumatic brain injury or something like that. Okay, starting to fumble over my words. I think this is the last slide. When it comes to vocational implications, you can imagine, based on what we've talked about, a person's social relationships, their biological functioning, their cognitive deficits, that kind of thing. You can just start to put the pieces together, I think, probably, of how this is going to affect work, given your understanding of it. But basically everything we've talked about affects the work life as well as a person's personal life and their social life and all that kind of stuff. Particularly the social and cognitive stuff, like what activities can I actually perform and how am I going to work with other people? Hold on a second. I fidget with my ring whenever I talk about this, and it just fell down on the ground and fell off. Is that a sign? I don't think it is, but I don't know. Funny anyway. So how do bosses and colleagues deal with me? How do they understand me? In families, there are stronger social bonds that hold people together in different ways than the work life just doesn't have. I mean, one of the phrases I keep hearing now is the job can't love you back, and neither can the people that are doing it or are around you while you're doing it, because you're there to perform. And if it's all about performance and you can't perform, what's your role there? So do bosses and do colleagues have a responsibility to be as patient and understanding as your kids and your wives or husbands or parents or whatever it is? It's an interesting philosophical question, but the reality is that if you can't handle yourself around customers, it doesn't make good business sense, and it's going to be harder, right? So finding the right kind of job that's going to be the right fit for what you can do is going to be crucial and important. Understanding limitations, same thing we've been talking about. Inability to recognize job errors. So when you're not performing the job, you think you are, but they say you're not. You can imagine how that conflict might come up, or the difficulty of a boss who doesn't know how to talk about those things, other than just say, like, you're not cutting it, see you later. So that's where a counselor can come in and kind of intervene and say, well, let's work through this a little bit differently, something like that. And then lastly, ability to perform increases without pressure of time or performance. So if you can find a situation where a person isn't constantly being given negative feedback about, like, you got to do it, you got to go faster, you got to do harder, you got to be better. If you can find a place that reduces some of that pressure or has a person who can guide in a way that's not so overwhelming, then a person doesn't experience so much of that cognitive flooding where they're just constantly overwhelmed with stimulus from the outside, both relationally and with, just the pace of activity, that kind of stuff. Then people can actually do things. Some of you maybe experience that. Like maybe you're watching this and you're just like so overwhelmed with the flood of new information that you're like, oh, I just want to shut down. I'm just like over this. My brain needs a rest. Imagine that happening to somebody in the situation, only it's more intense and more frequent, that they're just like, I'm overwhelmed now, I need to stop, I need to be done. Right? So with that said, luckily we are done. So this is the end of it. This was a little bit longer than the last one, and this week I've said I'm gonna do a little bit shorter, and they're not gonna be as long as I used to do, not even an hour. And now I've gone over an hour both times. So hopefully I can show you, I can build a little more trust with you and show you that I'm really trying my best to not be so long. But if you're still here with me, thank you. And I will hopefully do better and see you in the next one. All right, bye.